Good morning. Kevin volunteered to talk about the lumbar spine, and I eagerly volunteered to talk about the cervical spine, which is, I think, my favorite. Humans have the same number of cervical vertebrae as giraffes, interestingly. In fact, all mammals do, which is a bit surprising, but they just have larger vertebrae. 7 cervical vertebrae, 8 cervical roots. And the anatomy is pretty similar to that in the lumbar spine, except that we do have a vertebral artery, and we have a spinal cord in the lumbar spine. For the most part, we have spinal nerve roots, no cord. And in younger patients, we tend to see more disc pathology. In one study, the mean age of cervical disc herniation was 35 years old, and another it was age 28. So we tend to see disc pathology in younger patients and facet disease with stenosis in the older patients. On a normal MRI, we tend to see a fairly nice disc height, and the disc should look fairly white because of the proteoglycans retaining water, and as we age and degenerate and we lose the proportions of the glucosamine and chondroitin, and we tend to get disc desiccation, which appears black on MRI. Obviously, the muscles are part of the whole picture as well. Muscle fibers actually have very little in the way of, muscle has very little nerve innervation for pain, interestingly. So we talk about muscles hurting and that sort of thing, but there's not a lot of innervation within the musculature itself. We should all have a cervical lordosis as part of our norm, and as we age and get facet disease, we tend to lose that and get kyphotic cervical spines. All ages and both sexes are affected equally. Interestingly, there's a higher prevalence of cervical pathology in those who are better educated. It correlates with headaches, low back pain, and whiplash injuries. And interestingly, it's not as prevalent in patients who are physically active and athletic. There's little to no correlation between neck pain and the degenerative findings that we see on imaging studies, which is also, I think, kind of counterintuitive. We all get degenerative findings, and it may or may not be correlated, which makes it very tough for us to decide to determine what causes neck pain, what causes low back pain. Conversely, radiculopathy, which is pain going down the arm, is a lot easier to get a handle on and to diagnose. Myelopathy is the development of long-tract signs from cord involvement rather than root involvement. It manifests as gait instability, weakness, numbness, clumsiness, hyperreflexia, and other pathologic reflexes. Like in the lumbar spine, the dermatomes are very characteristic as we branch more distally, and it's pretty easy to correlate a specific nerve root pattern for the mid-cervical and lower cervical with a specific distribution. Axial neck pain is almost always treated non-operatively. We're not that good at fixing neck pain with surgery. We're good at treating radiculopathy with surgery, but not as successful with axial neck pain. Even with radiculopathy, 90% of patients get better within 6 weeks with conservative care, so we tend to usually be conservative unless there's a bad neurologic deficit or something along those lines. This is actually the lumbar spine, but it shows the spectrum of disc degeneration with normal, disc desiccation, but no bulge. This shows a bulging disc. This is a herniated disc. You have to have a degenerated disc to herniate, by the way. A thinning disc may be just a congenital variant. And then you can also see disc degeneration with varying degrees of osteophyte formation. And within the spectrum of disc herniation, we have disc bulging and disc degeneration progressing towards frank extrusion or sequestered or free fragment. This is a lumbar spine, but it does show a disc extrusion at L5S1, which would be expected to cause neurologic symptoms. The annulus is the peripheral portion of the disc. The disc obviously is cartilage. The nucleus in the center is quite gel-like in younger patients, and the annulus is like a steel-belted radial tire with cross-woven collagen fibers, actually quite strong. There's a posterior longitudinal ligament in the middle, right there, so most disc extrusions are off to one side or the other rather than being midline. The annulus is richly innervated with nerve fibers, so they can be quite painful, and that's a big component, if not one of the main components, for people to get neck pain or back pain from a degenerated disc. The center of the disc is typically avascular and does not have nerve fibers. There was a guy in Canada, by the way, who does all of his lumbar disc surgery under local anesthetic and some of his cervical surgeries. He has to numb up the skin. I mean, he does them, without general anesthesia, does them in awake patients. He uses local, so he has to numb up the skin. He does not have to numb up the muscle. He does have to inject local anesthetic into the periosteum, which has nerve fibers, in and around the annulus. And in a normal nerve root which is not compressed, they are not sensitive to the touch. But the ones that have a disc extrusion are very sensitive to the touch, the radiculopathy. So the muscular fibers do not generally have to be anesthetized in those patients. And there are, by the way, a lot of chemical mediators of pain, which is comes into play with say an annular tear with a chemical radiculitis. Some patients get radiculopathy and have no mechanical nerve root compression because of the chemical mediators. The most common finding with a cervical radiculopathy is the arm pain. It's really unusual to get sensory deficits in the hand without having arm pain upstream. And in those patients, we worry about things like carpal tunnel syndrome because it's universal for patients to have at least some shoulder and upper arm pain if they have a pinched nerve causing their distal sensory complaints. The C7 nerve root goes to the pectoral area, so sometimes we'll see a C7 radiculopathy manifesting, as a chest pain, and patients worry about having a heart attack, which of course has to be worked up and rolled out. But we do see sort of overlap between some of the cardiac presentations with a C7 radiculopathy, and often it'll be, weeks or months before a patient ends up being scanned with their cervical spine because they have pectoral or axillary pain. 68% of patients that, this is of course in one study, present with motor deficits, which takes a pretty thorough exam to really pick up subtle deficits, and reflex deficits, 71%. And there's all different versions or manifestations of pain, burning, throbbing, aching. Most patients do not have a history of trauma that present with an acute cervical radiculopathy. That's actually the minority. The cervical nerve foramini are actually lengthened or enlarged with neck flexion. It's the counterpart to the lumbar spine, where older patients with stenosis like to bend forward and use a grocery cart to walk in the store, and they can go further than standing upright. The neuroforamen is narrowed with neck extension. And that's I think the quiz question, by the way. So flexion increases the neuroforamen. The differential diagnosis includes the peripheral entrapment syndromes such as carpal tunnel syndrome, rotator cuff and other shoulder intrinsic disease, brachial plexitis, herpes zoster, which every once in a while will present without the characteristic rash, thoracic outlet syndrome, which is a little more difficult to pick up, sympathetic mediated pain syndrome, obviously various tumor conditions, infections, cardiac and other sort of organic problems. Stenosis we tend to see in the elderly, and because the facet joints can get degenerated, they can become lax and allow for degenerative spondylolistheses, such as, such as seen here. And this is an MRI scan that shows actual myelomalacia of the cord from the degenerative process here, which is both anterior from the disc osteophyte complex and the facet joints in the back. So sort of getting a nutcracker effect on the cord there. And that small white area, I don't know if it shows well, but that's myelomalacia of the cord. That is an absolute indication for surgery. These patients will become quadriplegic, if not quadriplegic, and that will progress. Our literature shows that cervical spinal stenosis with myelopathy is progressive. It is rarely catastrophic where somebody becomes suddenly paralyzed, but it's typically gradually progressive. Conversely, all humans, get some degree of stenosis as we age, and you can have cervical stenosis with cord compression. And the consensus at the North American Spine Society, this was a big discussion about 5 years ago, is do you operate on patients with cervical stenosis if they don't have myelopathy? And the consensus, 99%, is no, you don't. You follow them closely. They get followed clinically and with MRI scans. Although we know the disease will progress, the risks of operating on those patients are comparable to the risks of sitting on them, so we tend to watch them closely. When they did this statistical analysis to look at those risks, they found that the risks of getting breast cancer in a woman or prostate cancer in a man over the age of 50 was greater than the risk of paralysis when you have cervical stenosis. So they said, if you're going to operate on everyone with cervical stenosis, you should do mastectomies on all women over the age of 50 and prostatectomies on men over the age of 50, which would be absurd. So the consensus is that these patients can be watched and they don't have to have surgery necessarily unless they develop myelomalacia or objective signs of myelopathy. And it's actually very common to see patients go to surgeons, oh my gosh, you've got stenosis, you need an operation. And much of the time those patients can actually be followed clinically. Once a patient does, however, get any signs of myelopathy or any myelomalacia of the cord, those patients should be sent to a surgeon because that's a bad prognostic sign for progression. And we grade myelopathy 0 through 5, 0 being minimal and 5 chair-bound or bedridden. A lot of the work on myelopathy has been done by Japanese, in both Japanese literature and ours. And there's rating systems for that, 0 through 4 for upper extremity function, lower extremity function, including gait instability, sensory function, and then bladder function. Obviously, the higher numbers preferable. And we do see a lot of gait problems in patients manifesting from cervical myelopathy and cervical stenosis in patients over the age of 55. When we see it in the proximal cervical spine, patients almost always have hand involvement. Because these older patients have so many other reasons to get gait instability or clumsiness of the hands and that sort of thing, it's a little tough sometimes. They need a thorough workup to look for other causes. When we approach these patients, we usually do it through the front because the pathology is usually in the front. Furthermore, when you do it through the backside, the cord's in the way and you can't retract the cord to get to most of the pathology, and that's why you'll see most of the procedures we do through the front, some through the back, or some combined. The landmarks are fairly characteristic. We can get by typically with an incision about 2 centimeters in length transversely in a crease, and we can do a 4 or 5 level surgery through that small transverse incision. So it's very cosmetic. The reason I think most of us love neck surgery is because the anatomy's pretty, it's clean, it's not bloody most of the time, and it's interesting anatomy. The patients tend to do very well. Go down through the platysma, and you basically take the carotid sheath laterally with the sternocleidomastoid. This valley right here in your neck is basically what you're feeling the firm is your spine. Take the trachea and the esophagus medially with the strap muscles, and boom, you're down on the spine already. This is the plane right here. It's a nice clean plane. there are obviously a lot of risks with the surgery. The risks are very uncommon. The complication rate is quite low, but we do retract the esophagus. A lot of patients get dysphagia, which is on a later slide. The carotid sheath is there. Obviously, that's potential risk. And typically, we'll do. I think the most common thing we'll do for either disc pathology or stenosis is an anterior cervical discectomy and fusion. And through the front, we can go get the disc out, decompress the cord and the roots in the back, and then put a piece of bone in where the disc was, plate on the front to stabilize it. It's an easy surgery. It's pretty quick, and the patients tend to do fairly well. Sometimes it can be done outpatient or overnight stay, and for a one level or younger patient. We can reconstruct large defects with a cage. There's all types of cages out on the market, but a cage or a fibular graft or something like that, again, with some plate support. There's artificial discs in the neck, and I have to apologize to Kevin. Some of us I think there's different opinions as to artificial discs and the pros and the cons, and I think there's different enthusiasm levels amongst different people, but the industry-sponsored studies were actually, some of them a bit disappointing, and there's been pretty high levels of ossification anteriorly with the artificial discs, so that the motion preservation is always not what's desired. I think the concept in the neck with doing an artificial disc was because 2.9% per year incidence of adjacent segment degeneration above or below. So if we do a fusion, for example, at C5-6, 2.9% incidence per year of patients will develop disease above or below that might need to be addressed. And the survivorship analysis of that showed that at 10 years that was 25%. So it's not a trivial problem. I mean, 75% do not develop it. And so the thought was, we'll make artificial discs, we'll preserve the motion there, and that won't happen. And again, the studies sponsored by the manufacturers looked fairly good, but some of the other studies have been a little more disappointing. So I think that's sort of there's pros and cons, I think, of that. And I think at this point the gold standard is still fusion. The criteria for working patients up for the artificial disc is pretty rigorous as well. As far as there's a very long list of contraindications, and so I think it's just, I know some people have had very good experience with it, but I think there's sort of pros and cons of both. The posterior approach we can do if we have pathology that's more lateral, where we don't have to get to the other side of the cord, you might say. You cannot retract the cord. And I think very often we'll do a posterior approach to augment something in the front, or in any kind of unstable spine. We'll tend to go both front and back for fixation or decompression and fixation. In a lot of our revision cases, we have to do a combined approach, front and back. It's fairly simple, anatomy on the back. There's not as much back there. There's muscle layers, and you can peel those down, and a lot like in the lumbar spine, the lamina is more midline, as Dr. Yu said, and the pedicle and facet's a bit more lateral. And cervical laminectomy, like in the lumbar spine, is basically removing the midline structures, and that can be done in a stable spine that's maintained its lordosis. It does require taking a bit of the facet away, and so the thing we worry about is that patients might become kyphotic and get post-laminectomy syndrome. And this is an example of obviously a kyphotic spine that fell apart after laminectomies. It had to be reconstructed through the anterior approach. I think most of us would go anterior and posterior on that. Here's an MRI of a post-laminectomy kyphosis and a posterior reconstruction with implants. And the implants we use typically at C2, we'll use pedicle screws. We'll use lateral mass screws most commonly, C3 to C6. C7 does not have a very good lateral mass, so at C7 we'll typically use pedicle screws also, and most of us would extend that down into the thoracic spine to avoid destabilization at the cervical thoracic junction. And I have used, I think I've done 5 cases now with the Maser robotics to put the pedicle screws in at C7. It's not, they don't have the software out to do the robotics in the cervical spine. It's only, at this point, they only have software for thoracic and lumbar indications, but we just tell the robot that C7 is a thoracic vertebra, and we just mislabel it basically, and then we could still use the robotics to put C7 in. C7 is a pretty challenging bone to put pedicle screws in compared to anything further downstream. And so it's kind of, I think, been kind of nice to use the robot for that. So I've done some of these kind of deformity cases with the robotics going up into the cervical spine. Laminoplasty, I don't have a lot of experience with it. It's done a lot more in Asia, and there are some practitioners here in town. There's two people I know of that do them regularly. They're sort of first-line procedure for myelopathy, but laminoplasty entails basically doing a mini laminectomy on one side and just burring through on one side and then partially burring through on the other side to make a hinge basically, and hinging open like a trap door, swinging this open. It could close again, so then often it might be stabilized with small plates. And the few I've done, it's for me been a little time consuming, but I think maybe because I don't do a lot of them. But the results in the Asian literature are just as good as the other procedures we do. But again, I think most people for cervical myelopathy prefer to go anteriorly. The other thing is that you have to have a lordotic, thank you. No, it doesn't stick. Have to have a lordotic spine to do any of these posterior procedures, because if you, otherwise you potentially destabilize the patient. The advantage of laminoplasty here is that you've not fused the spine and you still retain the motion of the spine. It allows the cord to fall backwards somewhat, and there's been a lot of patients that get C5 and other nerve root palsies. When the cord comes backwards, it basically stretches the nerves, so that's a downside of it. But I think it's a good operation in the right hands for cervical myelopathy. And this shows the laminoplasty plates. It's just little plates put across to keep the trap door from closing shut again. And this shows a combined approach, anterior and posterior, which is the other option. We'll typically brace patients after surgeries if they are unstable or if they have osteoporotic bone. And many of us don't brace at one level anterior cervical discectomy and fusion in a patient with good bone. Some people do. I think my partner braces everybody, but it's sort of, I think the reason we came out with the anterior cervical plates was to give a little bit of fixation and sometimes avoid bracing. There's all kind of degrees of support and extent of bracing. Autograft, we used to use autograft always when we did anterocervical fusions, and we've got such good allograft products now that I think, and other products that we're using it less often. We'll still occasionally harvest an autograft, but we have so much morbidity from harvesting anterior iliac autograft in particular. I've personally had 2 pelvic fractures I've had to fix. It's like a crack in a windshield that propagates and the piece gets pulled off. So in 2 patients had to do an open reduction and internal fixation of their pelvis when they got a fracture. I've had 1 patient with a big belly who's an attorney get an infection that took months to clear up, and then we get meralgia paresthetica from sensory nerve involvement there. But the main complaint is that many patients get chronic pain, and the incidence of chronic pain from the harvest is up as high as 28% in one study. So the morbidity is high. So we don't take autograft as often anymore. And if we do, we might just make a little window and take just some marrow out without taking a structural graft. DVT, and I'd be very interested to hear Dr. Yu's opinions on this. DVT is not terribly common with cervical surgery. It's about 5%. It's in one study. Some people think it's much lower. It's very common after hip and knee surgery, a little less so after spinal surgery. So do you anticoagulate your patients or not? You put them on Lovenox for prophylaxis or sub-Q heparin. Some people do, some people don't. There's a lot of literature out there both directions, and it's pretty much surgeon's choice at this point. The types of spinal surgeries which give you higher DVT rates are obviously the more extensive surgeries, older patients, obese patients, smokers, but the big one is the longer procedures. So this is one study, ODU, and this is actually higher than in many other studies, 5.6% in cervical, 26.5% in thoracolumbar. Most of us actually feels quite a bit lower than this, but I put this slide in just to highlight that. So we do use sequential compression dressings. I think that's universal. I think everybody uses those. We'll occasionally put in a vena cava filter, either prophylactically or subsequently after we get the DVT. We try to get the patients up right away. I think most of us don't anticoagulate unless the patient's paraplegic or something in a trauma type setting. And again, it's sort of controversial, and there's no right or wrong answer. Some people do it, some people don't. But the risks of a catastrophic epidural hematoma can be, it can be truly catastrophic: quadriplegia, paraplegia. So that's the downside of anticoagulating or using prophylactic chemical agents in these patients. Kevin, do you give your patients Lovenox or sub-Q heparin?
After due time,
48 hours. I think Dr. Tantawaya, also, who's a neurosurgeon, I think he gives his patients sub-Q heparin or Lovenox, and I think my partners, Nevilaline and Moazis and Amory, do not, but I don't think there's any, the hospitalists have said, what you do you or don't you, and why not, and I don't think we can really, it's just, surgeon preference. I don't think there's, there's pros and cons of both directions, so. Dysphasia's even mild dysphagia is somewhat universal after doing these surgeries. Everybody will say they have a little trouble swallowing initially, and I have had some patients, particularly elderly patients, after big procedures that have dysphagia for a lot longer period of time, and I've had an occasional patient who I think it's been permanent, unfortunately, and it's due to our retraction. I used to put a manometer in the blood pressure cuff so I could measure the pressures. We retract the esophagus, and if we try to release our retractors pretty frequently. We try to do our surgeries fairly quickly, but some of them you can't rush too much when you're back around the cord. So we release the retractors pretty frequently and try to minimize the pressure on the esophagus, but certainly this has been, I think, one of the more common problems we've seen with anterior cervical surgery, which is our most common cervical surgery. But, unfortunately, it's usually temporary.